This is a 12-year-old boy with a history of developmental delay. He has bilateral posterior polar cataracts. The plan today is to implant a lens in the back, and I'll be doing a pars plana capsulotomy and anterior vitrectomy. He will not sit for a YAG capsulotomy later, we expect. So we'll do it all in one procedure. So before we go in the eye, I'm just going to create a little peritomy. Yes. So the question is that this is a posterior polar cataract, and the patient's at risk for PC rupture. So that's why we just have to be careful with that. The iris is normal, just widely dilated. You can see that there's some cortical spokes and this posterior polar cataract there. This is three and a half. Just proceed with the rest of the case for now. We don't have to deal with every bleeder, and we can deal with that later if we need to. Okay. So it's important in these cases to keep the infusion anterior. I don't like to run a posterior infusion unless you're very comfortable visualizing the entry site. You run the risk of causing retinal complications. If I do this, I always do a anterior and AC maintainer rather than try to do a pars plana infusion. The question is why we're doing all this. It's because he's mentally retarded, so he's not going to. When we assessed him, we felt that he would not sit for a capsulotomy. So it's better, in my mind, to do it now than to wait until later. We can do a very limited hydrodissection, so we have to make sure that the wave we put in doesn't go around. So it goes right about till there and stop. So I didn't go all the way around the back because you do run the risk of blowing out the posterior capsule. So stop there. Yeah, I don't want to do too much. I think if I can remove most of the lens without too much hydrodissection. Normally I like to do a lot more. The worry is if I use a lot of pressure, then I will blow out the posterior capsule. And again, we're going to be removing the posterior capsule, but the risk, you do run the risk of taking fragments and losing them. So you want to have this controlled as much as possible. Turn on the infusion, please. Much easier to put the infusion in if you have it running. Sometimes you can remove a lot of the periphery. What I'll do here is I'm going to remove some of the central lens material first. I'm trying not to remove the cortical material at the posterior portion of the lens intentionally, although that would make it faster. And the reason is that there may be an opening in the posterior capsule. It can enlarge very quickly once the fluid starts to circulate. So I usually save that until the end when I'm pretty happy with most of the removal of the lens material. Well, looks like I freed up that portion there, but I'm just looking underneath to make sure there's nothing in there. It's going to make things a bit easier. The goal is to try to remove as much as you can before you get to that point. If there is a posterior capsular break, you'll see a round hole sometimes, or even a membrane in the anterior vitreous. No, the posterior capsule is not broken, which is good. Yeah, it all looks very clear. If we're going to take out the posterior capsule, I just want to show you there's different ways of doing it. So some people will do it anterior approach. The other way is to do it posteriorly, and I'll just show you how we do it posteriorly. We can talk about, yeah, there's different ways. I'm just going to do it this way. It's actually, if you're learning, I find that this is the easiest way to do it from behind. That's what I think anyways. So what I was saying was if we're going to take out the posterior capsule, and normally, like for a 12-year-old boy, I wouldn't do this, but this is because of his particular situation. We're going to do that. So there's two basic ways of doing it. You can do it from the front or behind the lens. You can also do it before or after implanting the lens. And what I was saying was, and I've done all of these things, and you can also do it manually or with a vitrector. So there's many different possibilities or ways to do this. What I was saying was I'm just going to show how to do it from behind, and I find that actually, overall at least, it seems to have the least number of complications if you do it carefully. If you try to do it from the front, it can be very quick, but you can you run the risk of dislocating the lens and or causing vitreous to come forth and get incarcerated in the wounds. So what we'll do in this situation is we'll implant the lens first into the capsular bag and essentially complete the anterior portion of the procedure, and then go from behind and open the capsule. So we're going to be implanting a one piece in the bag. Don't want to do a wound assist here as much as possible. You want to really place it inside the bag. And with these lenses, it's quite easy. As much as possible, I like to place my sutures when there's viscoelastic. We're going to turn on the infusion when we tie. It'll help to flush some of the material out and prevent a lot of it just going to the back. So I often like to do an X shape or a cross bite to makes the tension equal on both sides. Just easier, quicker to close, just one knot. Turn on the infusion as well. So a lot of it will come out. So we don't have to worry about what's in the AC. So we just turned off the infusion just to prevent the eyes from draining too hard. And then it's hard to tie, or you end up making the knots too loose. So the advantage in these cases is that you can just bury the stitches underneath the conjunctiva there. Then we can turn on the infusion again. Yep. 3.5. Yeah. So let's just be off there a little bit. Can I get that 20 gauge MVR? So you go in parallel right angles, the sclera. So. And you make your hand flat. You want to be able to see the tip there. Okay. Make sure you're in the right spot. Okay. And then we just use the cutter to go in and go behind the lens. You can use a trocar for this too if you're comfortable. It's another way of doing the same thing. So hopefully you can all see the opening there in the posterior capsule. We make a small opening first Then do an anterior vitrectomy. The vitreous in children doesn't behave like it does in adults. It's a lot more solid. So you have to move the cutter around a lot more. If you only do a limited vitrectomy, then you leave some scaffolding behind for capsular opacity. So I'm just slowly enlarging the posterior capsular opening. Normally you want it a little bit smaller than the anterior capsular opening. One thing when you make your especially your posterior opening, you want to make it very smooth and you don't want to make it too large because you can push the lens backwards if it's really big. So just about what we have there is good, and then he won't get posterior opacification, and even if he gets L-shaped pearls, then they will fall off and they won't go into visual axis. They'll fall off into the vitreous instead. They won't cause any harm. I think that's. Can everyone see that? I think they're fairly well aligned there. So now I'm done, and I'm just going to keep it cutting as they come out. Just to prevent vitreous from getting incarcerated in your wound, because that's a potential complication. And I'm just using the cutter at the opening. That's the reason why any technique that you use, is even if you're coming from the front, you need to be sure that you don't incarcerate vitreous. And now we have to test it for vitreous. Can I get a Wexel, please? Okay, so there's no vitreous there. This is partial thickness. So I use a larger, use an 8-0 usually. So I don't want this wound to leak. I'm keeping the infusion running in this situation because I really want to make sure that I don't have a leaky wound here. You can use a trocar as well if you're comfortable with that. The only thing I would recommend, even if you use a trocar and you're not used to suturing your wounds, in a child I would always suture with my wounds because they do open up. And that's what our vitreoretinal surgeons do at our hospital with the children. And I have seen, even when they're sutured, these scleral wounds gape when I go back on these eyes for other surgery later on. I'm not ever as comfortable with the trocars because I like to be able to suture these wounds tight. I don't think that they ever are as good, but there's nothing wrong with it. You just have to use, this is 8-0 or 7-0, and make sure it's really nice and tight and watertight. The wounds, they're not sutureless wounds, even with the trocar, and children, because the sclera is much more elastic, so they do tend to spread a lot more. So that's the reason why I'm just comfortable doing this. Just going to check the wounds here. The sclera wound is not leaking at all, which is important. To put another stitch here. Can I put the 10-0, please? So you have to be very careful about the wounds in children. It's very easy for them to leak, and the children will, after waking up, can cry or scream or rub their eyes, and they're often difficult to examine right after surgery. So you really want to make sure everything is open because they're at greater risk for dehiscence because of eye rubbing and also for infections. Just going to move this stitch a bit further back. Same thing with this one here. So we're just going to close the conjunctiva, and you can cover up all of your other sutures in this situation with the conjunctiva. So he'll be a lot more comfortable post-operatively. Yeah, so I've taken a little bit of a scleral bite here just to sort of hold it. So I like to make sure the conjunctiva is well closed. The assumption is this child may at some point need other surgery. You never know. And I do, especially if you do glaucoma, you appreciate conjunctiva that's closed and not scarred up. So in children, glaucoma after cataract surgery is a big cause of, is a major complication of cataract surgery. So you have to be prepared for it, even though he's an older child. You just have to use the Tano again. So we have one thing left. Yep, could you just remove that, please? Thank you. So the lens will shift and shallow very, very quickly. Can I get the suture back, please? So there's a leak here. Yeah, same one back. That's why we always check. And it was too loose, so we'll just put another one in. So just to summarize, this is just the last stitch going in. So this is a boy with posterior polar cataracts, and we did a lensectomy with IOL, and pars plana posterior capsulotomy and anterior vitrectomy. Just check our wounds again. All right, that's it. We're done. Okay, thank you. Let's do the injections.